Welcome back. So what if the intestines are beyond repair? Let's know more about intestinal resection and anastomosis. Intestinal resection and anastomosis is the removal of necrotic and/or infected intestinal tissue and the consequent apposition of the two healthy intestinal segments together. This surgery is indicated for the removal of the vitalized or irresolvable obstructed intestinal segment or irreparable perforation of the intestines. Example causes are foreign bodies, intussusception, neoplasia, abscesses, trauma such as dog bites, neurologic disorders which affect the capability of the intestine to respond to nervous stimuli, or severe ulcerations. Resection of an intestinal segment must be planned with the blood supplies in mind. Do you still remember the blood supply to the jejunum? We discussed it in the first lecture video. The 12 to 15 jejunal arteries arise from the cranial mesenteric artery and anastomose in arcades near the intestine. From the terminal arcades, the short vasa recti bring blood directly to the intestinal wall on its mesenteric side. Why is the blood supply very important? Jejunal transection site must be planned so that each remaining free edge is near a jejunal artery. Sometimes this means taking more jejunal tissue than initially planned. For example, in this image, you can see that the foreign body can be transected in this region. The planned resection lines are signified by broken lines. However, the jejunal vessels are far from the edge, and this could compromise the healing of the wound. Since you will be taking this segment out, you need to make sure and you need to prioritize that the blood supply or the artery and the vessels, would be very close to the edge of your transection. In this example, in the right image, extra healthy tissue needs to be transected just so the blood supply would be near the wound edge. This will ensure that the wound will heal more optimally. But as you can see, you are now pressed with another problem. Look at the size of the lumen on both orad and aborad intestinal regions. The orad region is dilated due to the blockage. We already know how this happens. And the aborad one is of normal lumen diameter. How would you join the two if they have different sizes? This is what we call luminal size disparity. How do we fix this? Well, one way is to resect a wedge around 1 to 2 centimeters long, 1 to 3 millimeters wide on the anti-mesenteric border of the intestine with the smaller lumen. This enlarges the perimeter, giving it an oval shape. Do not try to narrow the intestine with a larger lumen. This will only lead to stricture at the anastomotic site when the dilated intestine contracts to a normal size. Remember, the dilated intestine will not stay dilated as long as you remove the blockage. It will go back to its normal size. So you have to make sure that when you join the two, this one should not be made narrower than it is because it will contract on its own after healing. Another way to do your transections is to do it at an oblique angle, as seen in this image. Transections are done with either a scalpel blade or a medicine bum scissors. This method equalizes the lumen size of both segments. Lastly, You may unequally place your sutures, the same way we discussed with prevention of dog ears in the first chapter. The sutures on the intestinal segment with larger lumen are positioned farther apart as compared to the placement of the sutures on the intestinal segment with a smaller lumen. This will make sure that your the two segments will be opposed um, in a good um, in a good manner that will promote healing and will prevent dehiscence. Now, how do we anastomose, or how do we join these two intestinal segments together? These are sutured together with appositional suture patterns. You may choose between a simple interrupted pattern or a simple continuous pattern. Now, Doc, why appositional suture patterns only? Any guesses? When we say appositional, if you remember with your surgery 1, we're just joining the two surfaces together. We don't want either edge to invert. We don't want it to invert as well. You just want them to be fixed together at the same position. Technically, gusto mo lang silang magdikit. Ayaw mong may pumaloob or lumabas. Okay. Now, why can't we use inverting suture patterns? When we use inverting suture patterns, we can be sure that there's no leak kasi paloob siya. So why can't we use that, Doc? Well, you cannot use inverting suture patterns for the intestine because the intestinal lumen is small as it is. It's already small. So if you invert your sutures and bring those layers inward, this will further reduce the lumen diameter and could actually cause stricture in that area. Now, on the other hand, everting sutures, meaning you want your layers to be puckered outward. Okay. Examples of these are your mattress sutures. This could actually cause increased adhesion formation with the other parts of the abdominal cavity. That's why we only use appositional suture patterns. You start apposition with two simple interrupted sutures. The first one is placed on the mesenteric border. All right. These are penetrating suture bites. You just place a simple interrupted pattern here. And then another suture bite, another simple interrupted suture on the anti-mesenteric border. Now, looking at these two sutures, this would actually divide your wound into two equal halves. And this would allow you to determine whether the two ends are of approximate equal diameter. Now, Doc, why are we suturing the mesenteric border first? Why? Why not start here? Why should we start here, Doc? Any guesses? I'm not gonna play the Jeopardy theme song again. All right. Now, the mesenteric suture is regarded as the most difficult suture to place because of the presence of mesenteric fat. This is also the most common site of wound dehiscence in an IRA. So you have to make sure that this is your first suture to make sure that the start of your anastomosis is correct. All right? The choice between a simple continuous pattern and a simple interrupted one remains to be the surgeon's choice. All right? It's all up to you. Some would prefer a continuous pattern because they experience less leakage with that and less suture bites are needed to oppose the two segments. Sometimes, with a simple interrupted pattern, some practitioners go overboard with the amount of sutures they place around the intestine. and that could actually create micro holes in the intestinal tissue, and that's where the leakage happens. In my experience with last year's class, it's true. When they tried, initially they tried to use a simple interrupted pattern, and we experienced a lot of leakage when we tried to check it. So they transected that area again, because if you get this wrong, for example, you experience a leak after you suture this, you cannot simply hindi mo basta-basta pwedeng paspasin lang and then you resuture. No. When this is sutured and then you experience a leak, you have to cut this again. Alright? You have to cut this again and then join the two, because these areas would be full of holes already. Oops. These would be full of holes, and that could actually compromise the wound healing and cause your sutures to dehisce. So we don't want that. So they shifted to a simple continuous pattern, and that was great. The cats are okay from during the post-op. I cannot be sure if they're still okay now, but they were all okay. There's no leak. Their suture patterns held even with the leakage check of more than 3 milliliters. It was good. So on my with my perspective and with my experience, I also do continuous patterns with this. Dahil kapag sumobra ka naman ng lagay dito, sorry. Kapag sumobra ka ng lagay dito, it's very hard to fix. For example, you put these four, okay? You completed the whole diameter of the intestine, and then you see a leak here. You put another one, and then you see a leak here. Then you put another one. You're just creating a lot of holes, and actually, most of the time, the leakage doesn't come from the incision line. It comes from the holes that you did from the suture. So be very careful, and I know you will choose the pattern that you think is best. After this is done, after you have successfully opposed the two intestinal segments, you have to suture the mesentery with a simple continuous suture pattern, being very careful with the vessels around that mesentery. After you are done suturing, make sure that you check for leakage, and you may proceed to omentalization. Make sure to lavage the surgical site and the abdomen, and count your sponges before you do your abdominal closure. Now, dehiscence is the #1 complication for an intestinal surgery. Overall rate of dehiscence of full-thickness intestinal incisions in dogs is between 12 to 16%. Most of the time, this leads to progression of peritonitis and further damage to abdominal tissue. So it is very important to prevent your sutures from dehiscing. How? #1, minimize contamination during surgery. The small intestine is full of intraluminal microbes, and when these microbes get in contact with other organs, it can easily cause contamination and infection. Make sure to aseptically pack the surgical area with your laparotomy sponges. The intestinal contents must be milked out, orad and aborad, from the planned incision and occluded well with forceps or fingers. Lavage the surgical area and catch all spillage with your lap sponges. Dispose of all lap sponges, gauze sponges, and replace them with new ones. Change your gloves and instruments before closure. #2, be mindful of the vascular anatomy. As we have discussed, make sure you transect the intestine at the point where the blood supply is close to ensure healing. You also have to minimize inflammation. Some inflammation is expected for good healing, but anything that prolongs or intensifies the inflammatory process is bad. Avoid using crushing instruments and traumatic instruments like rat tooth forceps, for one. Observe good aseptic technique and use atraumatic manipulation methods. Make sure to include the submucosa during suturing. Same with the esophagus and the stomach. The tunica submucosa is the holding layer, so make sure you include this in your suture bites. It is regarded as the thickest. The submucosa of the intestine is way thicker than the muscular layer, so it is the strongest layer. It retains its integrity when other layers lose their strength. Suture should be pulled just tight enough to make a seal. Too tight sutures can cause ischemia and hemorrhage. One important point is no to catgut. Alright? Chromic gut, catgut, what else? Surgical gut is sometimes the label for that. Do not use that suture because the primary mechanism of dissolution of catgut is inflammation. Right? So when inflammation happens and we expect it to happen, this will actually cause your suture to dissolve. We do not want that. Number 5, maximize the role of the omentum. The anastomosis site is recommended to be wrapped in omentum as well for better healing. Lastly, nutrition. Offer a small meal of highly digestible food when the patient has fully recovered from anesthesia. Intestinal healing is reliant on small molecules like short-chain fatty acids, glutamine, for the key nutrients of the enterocytes. Their presence in the intestinal mucosa stimulates enterocyte proliferation. So that is it for this chapter. I will be leaving you with a reading assignment to read about intussusception reduction. This reading assignment is downloaded from Clinician's Brief. It is also uploaded in our Google Drive under the folder of reading assignments. Make sure you read on this, and if you have any questions, please let me know. See you in our next chapter.